my sonographers are all cross when I mention Tony, because they all learned from me, and I always said, yeah, that's right, that's wrong, I don't know, you should do it better. But Tony, she came in and she had never scanned with me, and she just gave me hope that you could just, with a motivated boss and a great practice and looking online, that you could just learn it by yourself without much feedback. That was really great. So every time I mention Tony, my sonographers go, yeah, we know, Tony's great. Anyway, this is the last. So I used to have this in the main talk. I used to talk about the pouch of Douglas and the uterosacral ligaments in my main talk. And after doing the first workshop in Melbourne, probably 5 years ago, suddenly the next week, everybody was finding uterosacral ligament nodules, and none of them were true ones. And so I thought I'd just focus on the big things in the main talk, and then I'll take something out of that talk, just subtle findings in the pouch of Douglas, just with a word of warning. It's easy to have false positive results with this. So I'm talking just about little lesions on the uterosacral ligaments and on the posterior vagina. So, so basically, again here, just tiny things on the posterior vagina and on the uterosacral ligaments. And I just want to show where the uterosacral ligaments are, because it's very difficult to get your mind around where they are when you do a scan, and where you should look for those nodules. But basically, the uterosacral ligaments are quite close to the vagina, and if you press a little bit on the vagina, you'll actually stretch the ligaments over the vagina, so you look really, really close to the vaginal wall, and so we're just going to focus on this area here, the posterior vagina and the uterosacral ligaments. So lesions like this, they're not very important to pick up in isolation because the surgeon can just remove them. Or lesions like this, just little nodules on the uterosacral ligaments. So the first thing is obviously that you need to put the probe in the posterior fornix, so you're not going to see the uterosacral ligaments. And I'll just pause this for a second. I've got a son that does design, and I said to him, can you make me a model of a uterus with a vaginal probe and a uterosacral ligament nodule, and show where the... And he did. He knows everything there is to know about endometriosis. He's 18. So this is his model. So the vaginal probe usually sits in the anterior fornix. When you put it in the posterior fornix, see how the vagina stretches, and this is the uterosacral ligament, and you go really close to that uterosacral ligament. You can even you can see that if there was a nodule here, you would see it right in front of the vagina. And most of the time, if the ligament is normal, it's not going to be stuck to the vagina. But if there is a little nodule on it, often it gets scarred, and it gets scarred to the back of the vagina. And so you're really looking for something that is just sitting right on the back of the vagina. And very often, the fat around the vagina gets a little bit thickened there, and where you see that nodule, because everything gets pulled in. So we're looking for something really, really close to the vagina. So, and when we want to see the whole ligament, we obviously can't look in the midline. We need to go to the side and not put too much pressure on the vagina, or you're not going to see it. You also are never going to see it if there is no fluid in the vagina, because then the ligament is just sitting against the vaginal wall and you won't distinguish it as anything. So I'm going to try and show you some uterosacral ligaments that are normal, and then some nodules. So this is putting the probe in the posterior fornix. That's some free fluid, goes to the side without too much pressure, and that's a uterosacral ligament. So it's quite hyperechoic. On the other side, it's harder to see. And if I press just a little bit harder, it would just look as if it was part of that white layer that sits against the vagina. So it's only when you take the pressure off a little bit that you can see it, and you cannot see it if that fluid is not there. So, but if the fluid, and even if there is a lot of fluid, not everybody has the same sort of well-defined uterosacral ligaments. They're not always that easy to see. Even on laparoscopy, sometimes they're really defined and other times they're not. When it's retroverted, it's much more difficult to see. Even here where there is fluid, I can't see them. So then I just look at the vaginal wall and the white layer that goes over the top, and I just see whether that white layer is maybe somewhere pulled together and thicker, and then look for a nodule in that area. So putting the probe in the posterior fornix, this is a normal vaginal wall with a thin white layer, and then when you go more and more to the side, see how suddenly that white layer gets all thick and there is this hypoechoic nodule just here. It's stuck to the vagina. You can't move it up. The sliding is all happening here. So that's how close uterosacral ligament nodules are to the vagina. So you really need to just look for... The white layer often gives it away. It's not pathological in itself that it's a bit thicker, but if you then see a nodule in that area, that's a nodule on the uterosacral ligament. And it doesn't slide off the vagina, it sits stuck on the vagina. So here again, putting the probe in the posterior fornix, see that little hypoechoic nodule, thicker white layer. So that's a uterosacral ligament nodule, very small, in isolation. This just showing, this is quite a normal scan. The uterus going over to the ovary. The ovary here is quite mobile. And then going to the other side. And look, those little lesions, they don't matter very much, but I work in a public hospital and patients are put on a diagnostic list, and if they're on that list, then they can't have anything removed. So the more I can see, the more I can make sure that they're on the right list. So that ovary was moving nicely as well. This scan would, by all intents and purposes, be normal, reported as normal. But it's even sliding very nicely behind the uterus. But then when you put the probe in the posterior fornix, so that's a thin vagina, and then here you see how it gets a bit thicker, and then you see this black nodule very close to the vagina. So zooming in a little bit, it's a bit more clear. So that usually, to me, the sort of white layer grabs my attention, but in itself that's nothing. But then I'll look along there to see whether I can see a hypoechoic clump. Often it's tender, not always. And this is then in cross-section through the vagina. The vagina is here, but you see that sort of, there shouldn't be anything hypoechoic stuck to the back of the vagina normally. There's just a hypoechoic layer and that's all. And so I've got the video clip of this in a minute. So this is not even on the uterosacral ligament. This is on the posterior vagina. The uterosacral ligaments are sort of in an arch around this. And you can still see that even if there is a lesion on the posterior vagina, it often pulls the peritoneum. So you'll see that that white layer will again be thicker around the vagina. And this is the clip from that laparoscopy. So when you put the probe in the posterior fornix, you immediately see this hypoechoic nodule now in the midline, not on the side. So it's not on the uterosacral ligaments. The side is actually fine. There it's not abnormal. The side is normal, and then you turn it in transverse, and you can see normal vagina, and a little nodule just on the posterior vagina in the midline, and that was just what we saw on that laparoscopic image. But you can make them up, particularly on still images. I've got so many still images for, we found a uterosacral ligament nodule. It's not quite hypoechoic enough, but when you put calipers on it, you start doubting yourself. Yes, it looks like a little bit thicker there, but when you actually then push, see, you can bunch all of this up. This is just normal peritoneum, and but when you bunch it up, there's just different echogenicities in it. You can make it look as if that white is thicker, and you can make it look as if there's a nodule, so you have to be very careful in the beginning with false positive results. So these are just a few examples, a few examples, just so that you get an understanding. Again, that thick white layer, hypoechoic nodule, on it, and that's a typical nodule on the uterosacral ligament. So the issues are, these are difficult to see. I often got laparoscopic images from the patient trying to find them, and I couldn't find them. So it's a long learning curve. There are pitfalls. False positive results are common. So you can incorrectly interpret the image, or patients may already have had surgery and they may have some scarring on the back of the vagina or on the uterosacral ligaments that does not contain any active endometriosis. So then you'll send them for surgery when they don't need it. It is most useful in obviously women of the reproductive age group that have had no previous surgery, and where you correlate it really with the clinical picture. If it's really painful just when you touch it there and then the rest is not painful, then that's, I guess, relevant. I would suggest that you start looking for those little things when there are endometriomas, because to me, if there is an echo-filled cyst on the ovary and I cannot find anything else in the pelvis, then I even doubt whether it is an endometrioma. Then I wonder whether it might be a dermoid, because usually you can find something. Most of the time deep infiltrating endometriosis, but if there is no deep infiltrating endometriosis, usually you can find little nodules on the uterosacral ligaments. So to make a differential diagnosis of an echo-filled cyst, I just look carefully in the pelvis. So this is obviously a normal ovary here. Going to the other side, there's an echo-filled cyst, which at first sight I would think is an endometrioma. And then I like to see something else before I'm sure that it is an endometrioma. And so I'm just going to put the probe now in the posterior fornix, and the uterus is retroverted, but you can already sort of see that there's like sort of thickened white, little bit of a hypoechoic nodule there just next to the vagina. So that makes me then sort of more confident when that white layer is thick and there's a hypoechoic nodule that's stuck to the vagina, that that cyst is indeed an endometrioma. So, but I think in medicine we have to make a habit of two things. We have to at least, we have to help, or at least do no harm. And so there is no doubt, if you're looking for endometriosis, that you're going to help if the patient has this pelvis, because any preoperative warning will benefit the patient. The surgeon will do a much better job in one surgery. If the patient has a pelvis like that, you're going to help by looking for endometriosis, because you're going to give preoperative warning. And so, as I said, the old pathway can then be replaced by a new pathway in cases of that really bad endometriosis. However, if this is what you found, and that was the only thing you found, and you were right, then the surgeon is going to say, good on you, that was good, I mean, that was impressive, and remove it all the same. I mean, he didn't need any help to do that. He didn't need the preoperative warning. However, if you were wrong and they find a pelvis that is completely normal and you said there was endometriosis, then faith in ultrasound is going to crumble very quickly, and they're going to not use ultrasound anymore for preoperative assessment. So I think keeping the big picture in mind and just looking at major lesions is the way to go. So start with reporting certain findings. Are there endometriomas? Is there severe patch of Douglas obliteration? Are there bladder nodules or bowel nodules? Because for those, the surgeon needs help, and preoperative assessment is important. But if there are isolated subtle findings, remember that there may be false positives. So anytime you have just in isolation a bit of reduced mobility of the ovary, or a somewhat thickened ligament, or a possible small nodule on the uterosacral ligament, I would not report that. I would probably see whether it's tender, and if it is tender, report the tenderness and say that you cannot exclude endometriosis, because we can't, and then obtain feedback, because it's with more and more feedback that you then become more confident that those lesions are real lesions and that you can then make a difference. Particularly, I mean, some surgeons say it doesn't make any difference, and in private it doesn't. I mean, people go for their laparoscopy, and if it's a little lesion, it will be removed. But in public, where I work, it's not like that. People go for a diagnostic laparoscopy, and even if it's a little lesion like that, it's not necessarily removed. Then they're booked on an operative list. So it's disappointing that that needs to happen. So therefore, for that reason, I try to see those little lesions. Thanks to my sons for making the